Cognitive Therapy by Anne, Andrea, Elena, Kayla, and Sarah. Cognitive psychotherapy is a method of counseling based on the idea that thoughts impact behavior. The cognitive psychologist views behavior as an outward manifestation of mental cognitions and attempts to change behavior by attempting to change thoughts. It is worth noting that in practice, cognitive therapists tend to combine cognitive techniques with more measurable behavioral techniques, and so cognitive therapists are usually referred to as cognitive behavioral therapists. However, for the purposes of this presentation, we will focus on the aspects of therapy that relate to cognitive theory.
To help you understand the concepts of cognitive therapy and how they might be applied, we've created a fictional case study. Sylvie is a 30-year-old married mother of a 4-month-old daughter, Esma. Prior to the birth of her baby, Sylvie felt happy, but she has been feeling sad and withdrawn for the past few months, despite having a strong support network around her. Sylvie's doctor asked her to fill out a Beck depression inventory. Sylvie scored a 26, indicating that she was moderately depressed. On the inventory, Sylvie selected statements that described her, such as, "I feel sad all of the time and I can't snap out of it." And, "I have to push myself very hard to do anything." Although Sylvie's doctor has explained to Sylvie that she has postpartum depression, Sylvie would prefer not to take antidepressants because she is nursing her baby. Instead, she has been referred to you, a cognitive therapist. As we progress through the presentation, you can think about how, as a cognitive therapist, you might attempt to help Sylvie.
Foundations of cognitive therapy. Cognitive theory has its roots in the critical reaction to behaviorism and psychoanalytic traditions, and in response to developments in the 1950s in the fields of computer science, linguistics, and neuroscience, which spurred the advancement of computer information processing as a metaphor for cognition. Cognitive theory developed, in part, as response to criticism of the narrow scope of behaviorism, in particular its limited focus on observable behavior and environmental stimuli. While psychologists were beginning to address the limitations of behavior theory by exploring cognitive processes in the explanation of human behavior, advances in artificial intelligence, linguistics, neuroscience, and computer science provided a powerful metaphor for understanding the cognitive process, the computer. This cognitive revolution was seated at the 1956 Information Processing Symposium at the Massachusetts Institute of Technology, which brought together cutting-edge research from many disciplines. By the 1960s, cognitive theory was born, in large part due to the separate research and theoretical frameworks postulated by Albert Ellis and Aaron Beck, as they each became dissatisfied with the psychoanalytic tradition they were trained in. Beck's research into depression led him away from Freud's theory of anger turned inward as the cause of depression. In Beck's theory of depression, he postulated that a negative view of self, negative views of the world, and negative views of the future influence each other and create a cognitive triad that develops and maintains depression. Ellis's rational emotive behavioral therapy states that individuals possess a unique set of assumptions about themselves and the world, and that these assumptions determine how we interact and react to the world. Philosophy. Cognitive theory assumes that individuals process information cognitively through schemas, or the structure of our perceptions, beliefs, memories, learning, fantasies, and assignment of meaning, allowing us to selectively choose which information we attend to. Traditional cognitive theory postulated a linear connection between cognitive schemas, behaviors, and emotions, while current cognitive theory views the connection between cognition, behavior, emotion, and physiology as a network or a mode. On a fundamental level, cognitive theory states that how individuals think about events influences how they respond behaviorally, physiologically, and emotionally. These thoughts occur automatically and are both evaluative and brief. Psychological dysfunction is created and maintained by distortions in thinking. These distorted or faulty thoughts and beliefs must be challenged and replaced with accurate, healthy ones. Cognitive theories of personality have their roots in Bandera's 1969 social learning theory and Kelly's personal construct theory. Social learning theory understands personality as a complex reciprocal interaction between an individual's cognitive processes, behavior, and the environment, each affected by and affecting the other, while personal construct theory explains personality as the template or social construct an individual uses to perceive and understand the world. Current cognitive theory understands personality as the habitual patterns of thoughts of the individual, including what an individual thinks, the manner in which an individual attends to and processes information, and how they self-regulate thoughts and behaviors. The goal of cognitive psychotherapy is to replace maladaptive, distorted thoughts with accurate, healthy ones, and for the client to become autonomous. Cognitive therapy is goal-oriented with a focus on present thoughts and behaviors. Therapy is usually limited to between 8 and 16 weeks. Sessions are structured and require active participation from both the therapist and the client. The role of the therapist is collaborative, with both the client and the therapist setting goals and agreeing on techniques. There is an emphasis on psychoeducation, where the client is taught to understand the connection between thoughts, emotions, behaviors, and physiological responses, and to identify faulty or maladaptive perceptions, beliefs, interpretations, and assigned meanings. In this way, inaccurate or distorted thoughts are replaced with accurate, healthy ones. Cognitive theory relies on the idea of neuroplasticity to create change. Neuroplasticity can be defined as the brain's ability to adapt and change, or reorganize itself physiologically or functionally by creating new neural pathways. New thoughts, behaviors, and learning create new pathways in the brain. These pathways are reinforced and strengthened through repetition and practice, which forms new habits. Less used pathways become weak. In this way, it is possible to create new patterns of thoughts, emotions, and behaviors.
Many things have gone wrong for Sylvie to lead her to her current state of depression. To begin with, Sylvie's learning history has left her with cognitive distortions that have impacted her in her role as a new mother. For example, in moments when Sylvie is unsuccessful in helping her baby to stop crying, she personalizes, thinking, "My baby is mad at me." She also magnifies, thinking, "I am the worst mother in the world," while concurrently minimizing her other successes at attending to her baby's needs. Sylvie is also struggling because of personality dimensions, such as sociotropy. She was previously very involved with friends in the workplace, often going out for lunch with others, but those interactions have been disrupted since Sylvie stopped working when she had her baby. Finally, Sylvie has a negative cognitive triad of viewing herself, her situation in the world, and her future as all being hopeless.
Concepts. The three fundamental concepts in cognitive therapy are collaborative empiricism, Socratic dialogue, and guided discovery. The first concept of collaborative empiricism outlines that the therapist and client work together to determine the treatment goals and will become co-investigators when it comes to examining and modifying the client's cognitions. The second concept is Socratic dialogue, and it outlines that the therapist will design questions to ask the client in order to promote new learning. Questioning is utilized in the beginning and later stages of cognitive therapy, and the therapist will use questioning when utilizing various therapeutic techniques. The final concept is guided discovery, and it allows the patient to modify both maladaptive beliefs and assumptions. In this relationship, the therapist will serve as a guide who designs behavioral experiments using the client's problem behaviors to lead the client to acquiring new skills and perspectives. Cognitive therapists work in various settings, and sessions typically last 45 minutes. Throughout cognitive therapy, clients may also be asked to complete assessments at the beginning of each session, such as the Beck Depression Inventory or BDI. Confidentiality is always maintained, and sessions often occur on a weekly basis. The therapist may also suggest the inclusion of a significant other, family member, or friend. During the initial session, the therapist will aim to build a relationship with the client. This may involve the therapist asking questions about the client's thoughts and feelings. The therapist will also discuss cognitive therapy with the client, which allows them to understand the therapy and deal with any misconceptions they may have. The initial session will also involve defining the problem and providing symptom relief. During these sessions, the therapist will take on more of an active role than the patient, and homework will be assigned at the first session. As the therapy progresses, it will move away from symptoms and begin focusing on patterns of thinking and the examination of automatic thoughts. During these sessions, the therapist moves into a less active role of advising. The emphasis is often on cognitive techniques and will focus on more complex problems. The frequency of sessions will begin decreasing as the patient becomes more self-sufficient. The termination or ending of treatment occurs when the goals identified initially have been met and when the client is able to utilize the skills independently. Termination is planned for during the first session, and the therapist indicates that the therapy is time limited. After the termination, there is often 1 to 2 booster sessions, which are used to discuss successes and assist the client if needed. Techniques. Cognitive therapy utilizes both cognitive and behavioral techniques. Beck, Rush, Shaw, and Emery in 1979 indicate that cognitive therapy is designed to, in quotes, 1. Monitor their negative automatic thoughts or cognitions, 2. To recognize the connections among cognition, affect, and behavior, 3. To examine the evidence for and against distorted automatic thoughts, 4. To substitute more reality-oriented interpretations for these biased cognitions, and 5. To learn to identify and alter the beliefs that predispose them to distort their experiences. End quote.
In the initial sessions, you attempt to build a relationship with Sylvie and really come to understand her problem. You allow Sylvie to come up with the goals for therapy. Sylvie wants to no longer feel depressed, but after some discussion, she comes up with the specific goals of getting out of bed and dressed every day by 8 a.m. and socializing with friends at least once per week. Over the course of a few sessions, Sylvie becomes comfortable setting the agenda for each session. She is also given homework assignments to complete between sessions. For example, you ask her to keep a journal of thoughts that minimize her successes and maximize her failures. Her responses in the journal include phrases like, "I have no idea how to stop Esma's crying. I'm so useless." And, "Esma finally had a decent nap. Too bad all I got done was the dishes."
Verbal techniques are used to elicit the patient's automatic thoughts, analyze the logic behind the thoughts, identify maladaptive assumptions, and examine the validity of those assumptions. Automatic thoughts are often obtained when the therapist questions the client about the thoughts that are present during upsetting situations. Role-playing or imagery can be used if the client is having difficulty identifying or recalling the thoughts. Examining these thoughts can lead the client to cognitive change. Maladaptive assumptions appear as themes in the client's automatic thoughts. The assumptions can often be hard to identify, but once one is identified, it is then open to be modified. Modification can be done by questioning or challenging by the therapist. Cognitive techniques. Decatastrophizing, or the what-if technique, can help the client prepare for feared consequences and help them identify problem-solving strategies. This cognitive technique is often paired with the time projection technique. Reattribution will test the client's automatic thoughts and assumptions by allowing them to consider alternate causes of events. This technique encourages reality testing and the appropriate assignment of responsibility. Redefining is used when the client believes the problem is beyond their control. The therapist will then instruct the client to redefine the problem. Decentering is primarily utilized with anxiety patients who believe that they are the focus of everyone's attention. After the information is obtained by the therapist, they will then design a behavioral experiment to test the client's belief. Beck and Weishauer in 2014 said that behavioral techniques are used in cognitive therapy to, quote, modify automatic thoughts and assumptions, end quote. Homework allows the client to practice the skills between sessions. Hypothesis testing involves first framing and then testing a hypothesis created by the client. The testing of feedback can include the monitoring of behaviors and requesting feedback from those surrounding the client. After this is done, the client is then able to come to a new conclusion. Exposure therapy is used to provide data on the thoughts, images, physiological symptoms, and self-reported level of tension that is being experienced by the client. This technique is often used with anxious clients. After data is provided, the therapist and client can then discuss why some of the thoughts, tension, etc. are not always accurate. Behavioral rehearsal, or role-playing, is used to practice and strengthen the skills learned in session. This is often videotaped so the client can evaluate their performance prior to utilizing the skills in real life. Diversion techniques are used to divert the client's emotions and thinking to other outlets such as physical activity and social connections. Activity scheduling involves the client rating their level of pleasure experienced during activities and is used to provide the client with structure and to encourage involvement in various activities. Graded task assignment allows the client to begin initiating an activity at a non-threatening level while the therapist gradually increases the difficulty level.
In middle and later sessions, you use questioning techniques to help Sylvie to analyze some of her negative automatic thought patterns and replace them with more positive and realistic thoughts. For example, you ask Sylvie if she is ever good at stopping Esma's crying. In what ways does she have success? Is it possible that even the best of parents are occasionally unsuccessful at comforting a crying infant? Eventually, Sylvie adopts thoughts more like, I'm often good at helping Esma to stop crying, This is just a challenging moment for both of us. She'll probably settle down within the next hour, and I can handle that. One of Sylvie's homework assignments involves posting sticky notes to her bedroom and bathroom mirrors with particular thought patterns that she is trying to adopt, such as, "Parenthood is hard, but I am really trying and I've learned so much." One of your goals is to provide Sylvie with cognitive strategies that allow her to essentially act as her own therapist, even after therapy has been terminated.
Evidence. Cognitive therapy falls under the category of evidence-based practice in psychology. This means that it is based on empirical studies and evidence. Cognitive therapy has been studied using both randomized controlled trials and meta-analysis. According to Beck and Weishauer in 2014, both randomized controlled trials and meta-analysis have shown that cognitive therapy is a successful treatment method and that it is especially successful in the treatment of anxiety and depression. Limitations. Even though cognitive therapy is empirically supported by randomized controlled trials and meta-analysis, some criticize randomized controlled trials because the samples used are screened to prevent comorbidity. This can result in the possibility that the sample does not accurately represent the general population because clients often have more than one issue. Even though cognitive therapy is effective for a variety of people with a variety of disorders, in order to treat bipolar disorder, psychotic depression, and schizophrenia, cognitive therapy should be used in conjunction with other treatment methods, such as medication. According to Beck and Weishauer in 2014, cognitive therapy works for people who fit into the following two descriptions. In quotes, they have adequate reality testing, good concentration, and sufficient memory functions, end quote, and they, in quote, can recognize the relationship among thoughts, feelings, and behaviors and take some responsibility for self-help, end quote. There are a variety of people and disorders that would fit into these categories, but there are also people that are unable to fulfill this criteria, and therefore cognitive therapy would not be a good choice of treatment for them. Multicultural applications. According to Gerald Corey, cognitive therapy is seen as being effective for a variety of populations. This range of populations includes, in quotes, patients with different levels of income, education, and background, end quote, as indicated by Pearsons, Burns, and Perloff in 1988. As a result of cognitive therapy's focus on clients' values and beliefs, it is crucial that the therapist understand the cultural context that the client is coming from, because, according to Beck and Weishauer in 2014, the client's, in quotes, beliefs, values, and attitudes, end quote, are a part of and come from their cultural background and context. It is also important that the therapist refrain from imposing their own beliefs on their client. Beck and Weishauer believe that cognitive therapy should be effective cross-culturally because the desired outcome of cognitive therapy is to help clients think in ways that help them achieve a state of emotional well-being, regardless of culture. One way that cognitive therapy needs improvement in terms of multiculturalism is that it is mostly used in developed nations and has yet to be expanded into less developed countries. Future directions. Beck and Weishauer in 2014 stated that cognitive therapy will continue to be popular in the future because 1. Cognitive therapy has grown quickly since the start in the 1960s, in part because of strong empirical support for it. 2. Cognitive therapy is teachable and accessible for therapists. Beck and Weishauer write that a therapist can become trained in cognitive therapy relatively quickly, often in a year. And 3, the short-term approach inherent to cognitive therapy will likely continue to be popular in today's world and in the future. In the future, cognitive therapy hopes to expand further. One field of interest is in social psychology. Thank you for listening to our presentation. We hope it was informative for you. If you would like more information about cognitive therapy, please check out the references in the last few slides. Thank you.